Welcome back to The Explainer. Today, we're diving headfirst into a topic that, honestly, is surrounded by a ton of noise, a lot of outdated info, and just plain misunderstanding. We are talking about autism spectrum disorder. We're going to completely toss out the myths today and rely strictly on the latest evidence-based guidelines from the World Health Organization, the CDC, and the American Academy of Pediatrics to really demystify autism. By the time we wrap up, you'll have a super clear, structured, and genuinely modern understanding of what autism actually is. Okay, let's dive into this. Here is our roadmap to break down all this dense medical science into a really manageable journey. We'll kick things off by defining the spectrum, peek inside the brain, map out the early signs and diagnosis, explore evidence-based therapies, trace real-life outcomes, and then finally we'll tackle those stubborn myths and look at the future of care. All right, Section 1. Understanding the autism spectrum. We're going to clear the slate of old assumptions right here. I want to start off by posing this question directly to you. What does the spectrum actually mean? Because for the longest time, people thought of the autism spectrum as just a simple, straight line. You know, like reading from less autistic on one end to more autistic on the other. But medically and practically, that just isn't accurate. When we say spectrum, we are talking about a vast, entirely unique, and truly multidimensional range of strengths, challenges, abilities, and support needs. Two individuals on the spectrum can look completely different in how they communicate, how they learn, and what kind of daily support they might need. It is highly, highly individualized. So, let's break down the official definition based on the latest DSM-5-TR guidelines. Autism Spectrum Disorder, or ASD, is a neurodevelopmental condition. And notice I didn't say mental illness, because it's not. It's fundamentally characterized by two core domains: persistent differences in social communication and interaction, right alongside restricted, repetitive behaviors or interests. But, and this is absolutely crucial, I want to draw your attention to a massive shift driven by the neurodiversity movement. We are increasingly viewing these characteristics as differences, not inherent deficits. It's really just a different way the brain is wired to experience the world. Now, what's really interesting about this is how easily we can completely dismantle some of these pervasive myths that have been floating around for decades. Let me be unequivocally clear, based on all major scientific and pediatric guidelines. Autism is absolutely not caused by poor parenting, and there is no way it is caused by vaccines. Instead, it's a neurodevelopmental condition with highly complex, multifactorial origins. That just means it's born from an intricate interplay of genetic and environmental influences that actually occur before a child is even born. Which brings us nicely to Section 2, inside the autistic brain. Let's shift our focus to the microscopic level here. The neurobiology of autism is just endlessly fascinating. Did you know there isn't just one autism gene? Scientists have literally identified hundreds of associated genes that interact with environmental factors during prenatal brain development. And one of the coolest mechanisms at play here is something called synaptic pruning. Okay, so in a typically developing brain, neural connections that aren't being used get pruned away. Think of it like a gardener trimming a bush so it grows right. Well, in the autistic brain, this pruning process happens differently, and that leads to altered neural connectivity. Plus, we know ASD is sometimes associated with specific genetic conditions like Fragile X or Rett syndrome. It's like a giant biological puzzle. All right, moving from the biological why to the practical how in Section 3, signs, senses, and diagnosis. Let's look at what early warning signs look like in everyday life, starting with the earliest developmental milestones. Before a baby even turns 1 year old, there can be some subtle signs. We're talking limited eye contact, maybe a lack of social smiling, a limited response when their name is called, or reduced babbling. And why do we focus on this so heavily? Because early identification is arguably the most powerful and compassionate tool we have. Spotting these differences in infancy means parents and medical professionals can introduce supportive, loving systems incredibly early, which the data shows massively improves long-term functional outcomes. Let's move forward and see how this builds as that infant becomes a toddler. Between 12 and 24 months, the diagnostic criteria sort of evolve alongside the child. You might start to see delayed speech, or maybe a lack of pointing to share interest. You know, like a toddler pointing at an airplane in the sky just to make sure you see it too. You might also notice reduced pretend play, or the emergence of repetitive behaviors, like intense hand flapping, rocking, or lining up toys in a very, very specific order. But you know, it's not just about behavior, it's heavily about how the brain processes the physical world. Just imagine the lived experience of these sensory processing differences. On the hypersensitive side, the overresponsive side, Imagine if the hum of your kitchen refrigerator sounded as loud as a jet engine, or a standard classroom fluorescent light felt blindingly intense. That's incredibly overwhelming. Then, on the hyposensitive or under-responsive side, you might see a child who has an unusually high pain tolerance or who actively seeks out deep pressure or constant spinning movement just to feel regulated and grounded. So, with all that in mind, how do doctors actually confirm a diagnosis? Well, it's a multi-layered journey. It usually starts with a deep developmental history and parent interviews. Then we bring in screening tools like the MCHAT questionnaire. If that raises a flag, a specialist will conduct a formal diagnostic assessment, relying heavily on standardized play and observation tools like the ADOS-2. Finally, physical and genetic testing might be done just to rule out other medical issues. The big takeaway? There's no single blood test or quick brain scan for autism. It relies entirely on expert clinical assessment and behavioral observation. And this brilliantly illustrates exactly why clinical expertise is needed. Differentiating autism from other conditions is super complex because of how much the symptoms overlap. ADHD, for example, shares some traits, but it lacks the core social and repetitive features of ASD. A language disorder involves speech delays, but without those restricted behaviors. And an intellectual disability involves global cognitive delays, which actually can co-occur with ASD, but it is its own distinct diagnosis. Okay, Section 4, Evidence-Based Support and Therapy. Let's shift our narrative toward actionable hope. I want to make an absolutely critical point right off the bat. There is no cure for autism, and modern medical consensus dictates we shouldn't even be looking for one. We're focusing on empowerment. We use individualized, respectful, multidisciplinary interventions to support the person. This might include speech therapy, using visual tools like PECS, which uses picture exchange to communicate, or digital AAC devices that actually give a voice to non-speaking kids. We've got occupational and physiotherapy for motor skills and daily living. We also see great success with naturalistic developmental behavioral interventions, or NDBIs, which are all about play-based learning. And of course, specialized educational support through IEPs and parent-mediated programs ensure this support isn't just happening in a clinic, but is part of the child's real everyday life. Moving on to Section 5, Real Lives and Outcomes. Let's take these abstract medical guidelines and map them onto a real human story. Let's actually walk through this chronological journey to see how appropriate support changes lives. Imagine a toddler named Leo. At 18 months, Leo receives a diagnosis and begins early intervention that's primarily focused on speech and engagement. Fast forward to preschool, and Leo's needs naturally shift, bringing in occupational therapy to help him navigate some sensory sensitivities. By school age, the focus evolves again to classroom accommodations and practicing peer social skills. And eventually, in adulthood, Leo's support transitions into vocational training and independent living skills. It just goes to prove that tailored, evolving support empowers autistic individuals to lead fulfilling, independent lives at every single stage. Finally, Section 6, Myths, Facts, and the Future. Let's look ahead. The future directions for autism care are incredibly exciting. Researchers are making huge leaps in genomics, looking for biological markers that might help us identify autism even earlier than we can with just behavioral observation. We're even seeing artificial intelligence being tested to help parse out those complex diagnostic overlaps we talked about. Precision medicine is aiming to tailor digital therapies specifically to a person's genetic makeup. But honestly, perhaps the most important thing on the horizon is the massive societal push we're seeing for genuinely inclusive education and better community integration. So, the crucial point is summarized beautifully by this thought drawn from our clinical sources. Autism is characterized by differences, not deficits alone, and respect for neurodiversity is what truly helps autistic people reach their full potential. It forces us to ask a final, provocative question as we wrap up today. How can we as a society better shift our focus from fixing deficits to supporting differences? Thank you so much for exploring this with me today. Keep asking great questions, and I'll catch you on the next explainer.